MURTHY sir session will be followed by Dr. Shiv Kumar. So we would like to give a warm welcome to him as well. And he's a chief neonatologist at OM Hospital. Dr. Shiv Kumar, welcome on behalf of NNF Karnataka State Chapter.
Thank you, sir. Yeah, thanks for giving me the opportunity.
So I think the topic first one, he's going to talk on the physiology. Sir Srinivas sir, with your permission, can I ask Dr. Shiv Kumar to start first and then followed by your talk? Is it fine, sir?
Yeah, I don't mind. Actually.
Yeah, Dr. Shiv Kumar, can you start because we'll be talking on the basics physiology. So I request you to start the session first. Followed by that, Srinivas sir will take up the session on non-invasive ventilation.
Sure. I just share my screen. Yeah.
There is a chief neonatologist from St. John's Medical College. So I request Dr. Shiv Kumar to please start the session. Thank you. Dr. Shiv, yeah.
Can you see my screen?
Yes. Can you speak a little louder?
Okay, just a minute.
You're audible, but if you speak louder, it will be good.
Is it any better now?
Yeah, better. Please start the session. Thank you.
Okay.
And please try to keep up the time so that we spend maximum time on discussion because there will be a lot of doubts. And this is the first session on neonatal respiratory chapter, what we are going to start. And this entire 1.5 to 2 weeks, we'll be discussing neonatal respiratory chapter. Over to you, Dr. Shiv Shankar.
Okay, thank you, Dr. Prashant. Thanks. Good evening, everyone. Thanks for this opportunity, NNF Karnataka chapter, for giving me and making me a part of Neo Master E class. To begin with, not wasting much of time. So today's topic is the first topic of respiratory symposium, I would say, is mainly on respiratory physiology in preterms and HFNC. The subsequent NIV will be dealt by SRINIVAS sir. So although the respiratory physiology is a very big topic, I would like to cover most of them in the stipulated time and restrict the physiology only dealing with NIV. If any questions are there, I would be happy to answer. So the first slide on this would be the evolution of neonatal respiratory care, or we should know about this, is how we have evolved in neonatal respiratory care. So right from 1960s, when neonatology came into existence, we were treating the babies with hood oxygen. And then the realization of the oxygen toxicity, then RDS, was not being treated, surfactant didn't exist at all. Then the first generation of ventilators started coming up in 1960s. And then, non-invasive ventilation, although existed in 1950s, but until the first paper by Grigori et al. Came in 1970s, and then nasal Cpap, started coming in. Then high frequency ventilation, we all know, came a little bit later. And the first thing, which has revolutionized the care in respiratory distress syndrome is surfactant. We all know how it has changed the treatment of RDS, from early 90s to until now, and probably in the future as well. Until 2005, we were using all conventional ventilators. And then neonatologists realized that it's the volutrauma, which is more dangerous than barotrauma. And then newer generation of ventilation came into picture. So the volume guarantee came into existence about 2005, and then we use it now full-fledged, including the NIV. Okay, so in the last 10 years, use of NIV has been tremendous, and that's the primary mode of respiratory care right now. The previous one was the Western context, how the neonatal mortality has decreased over a period of time. But in Indian context, it has changed tremendously. Respiratory care is one of the mode, where the neonatal mortality has come down. Look at the numbers, from 80 to 85 to currently we are about 22 to 23. The same inventions, and look at the neonatal mortality rate, how slowly and gradually it has come down to about 22. And most of the seniors in this forum have contributed to it quite a lot. So, we are very thankful for you. So to begin with physiology, the first slide, which we all know from Hippocrates right from 4th century BC, is primum non nocere, which does mean that you shouldn't do any harm first. And since we are neonatologists are dealing with taking care of babies, immature lungs, I would say, and gas exchange, and dealing with sophisticated instruments like ventilators, we need to know physiology much better, because these sophisticated instruments by their primary nature can harm the neonatal lungs, which are in developing stages. So it is utmost importance that we need to know and have adequate knowledge of physiology. Before physiology, not taking more than one slide, I'll talk about the development of lungs. We all know into the 5 stages: the embryonic, pseudoglandular, canalicular, saccular, and alveolar phases. It arises from the primitive foregut. Okay, right from about 17 weeks, the appearance of surfactant starts slowly, and it is detectable in the amniotic fluid from 27 to 36 weeks. The cohort, the preterm cohort, which we primarily deal with, is from 22 to 23 weeks up to 34 weeks, which we are really worried. So at that point of time, the surfactant is detectable, but it's not sufficient. So when you take about neonatal physiology, I would say start with children are not equal to small adults, and neonates are not equal to small children. It is not wrong to say that small neonates, the term infants, are not equal to preterms. Okay, why? Because because of various factors. First one is unfavorable chest wall mechanics. I'm going to talk about this in little bit details in the further slides. Second is immature respiratory control. Because of the prematurity, the respiratory center is not matured enough. Third is limited muscle strength and endurance. Short inspiratory time, high respiratory rate, and increased airway resistance. We all know these factors day in and day out when we are dealing with babies with RDS. We all know that these factors come into existence every day, but we need to know a little bit about why these factors come into play. Okay, so understanding the physiology is very important. Can have a look at this picture and see that the preterms are at mechanical disadvantage by many factors. First is the shape of the chest is very important. In adults, it is of ellipsoid shape, whereas in preterms and term neonates, it is more horizontal, cylindrical. That puts them at a great mechanical disadvantage. The horizontal ribs placement. Okay, so that again, I'm going to talk a little bit detail in the further slides. Horizontal attachment of the diaphragm, so that the course becomes very shorter. Compliant chest wall. This is very, very important. In the video, you can clearly see how compliant the chest wall is. The compliant of the chest wall is too much due to pliable ribs, weakened muscles, less fatigue resistant, muscles in the external intercostal muscles and the diaphragm. Ideally, an adult or a big child would have about 50 to 60% of the muscles which are fatigue resistance, whereas in preterms and neonates, it's about 20%. Okay, and the last important factor, which we all know, it's increased surface tension due to surfactant deficiency. So they are put at mechanical disadvantage. The poor baby has to deal with all of these, if he or she is sick. So basic understanding of neonatal physiology comes with the understanding how does it work. It works as a pump and a load. Okay, imagine the respiratory system as a pump, that is the external thoracic cavity, the thoracoabdominal wall and its muscle acts as a pump, and the load which it has to bear, it is elastic and resistive properties of the chest wall and the lungs. All right, so if you understand this, the things becomes much easier in the subsequent slides. So this is just a simple figure which I'm going to talk again in details. So if you see, there are 3 kind of pressures which we need to know before understanding the detailed physiology. First is intra-alveolar pressure. It is equal to the atmospheric pressure, which is about 760 millimeter of mercury in an equilibrium stage. Okay, so intra-alveolar pressure is equal to the atmospheric pressure in an equilibrium stage. Intrapleural pressure, which the name depicts itself, that it's a pressure between the pleura. And transpulmonary pressure, the pressure difference between intra-alveolar and intrapleural pressure. Okay, it's also called transmural pressure. Mural is across the wall. All right. So what are these lung pressures? How do we define them? Intrapulmonary pressures, okay, it can be positive or negative. So if you see this figure, this is your atmospheric pressure, and this is the intrapulmonary pressure. So what happens when you breathe in, when you take inspiration, okay, when you inspire, the air goes in, all right? When air goes in inside the lungs, the volume of the lung increases. As we know from the Boyle's law, that volume is inversely proportional to the pressure. When volume increases, the pressure drops. You can see here, the pressure goes from 0 to -1. What happens when the pressure inside the alveoli or the intraalveolar pressure becomes negative? It sucks the air in, okay? That's how the air goes in. And when you expire, air goes out, volume decreases, pressure increases, it goes to +1, which is above the atmospheric pressure. Atmospheric pressure is negative, so it sucks the air out. That is a simple physiology of respiration. What happens to the intrapulmonary pressure? Intrapleural pressure. Intrapleural pressure is always negative. Remember, intrapleural pressures are always negative, whereas intrapulmonary pressure, which I've told in the initial part, can be positive or negative. Why is intrapleural pressure negative always? It varies from -3 to -6. In others, it can vary from -5 to -7. All right. So imagine there are two antagonistic forces which are acting. One is the natural tendency of the lung is to recoil. That means when you stretch a rubber, it comes back to its original position. Okay. That is the natural tendency of the lung is to recoil. Similarly, the chest wall outside tries to expand. So there are two antagonistic forces which are acting harmoniously against each other. So when two forces acting each other, there always creates a negative force. So imagine take two glass slides, place a drop of water, place them together and try to separate them. They don't move. There is some negative pressure. Similarly, the pleura acts. It is always negative. In inspiration, they become more negative. Okay, that's why the alveoli opens. So the force that determines the entry of air inside the lungs is the difference between intrapulmonary and atmospheric pressure. There has to be a difference for the air to go in. The force that determines the opening of alveoli and opening of the lungs is your transpulmonary pressure, the difference between intrapulmonary and intrapleural pressures. All right. This intrapleural pressure, it becomes more negative. That means less negative towards the positive side. The transmural pressure becomes very less, and then the lungs won't open. So the next terminology which we need to know is compliance. What does compliance mean? Okay, it is a change in lung volume. That means any change in lung volume from inspiration to expiration with application of certain pressure. That is a change in delta pressure. If you apply a pressure and the lung volume moves from 3 ml to 5 ml, that change in lung volume by the amount of pressure which you have applied is your compliance. All right. The two types of compliance which we know is a static and dynamic compliance. Static, the word itself signifies, is when the lung is in resting position. When the lung is in resting position, there is no air moving in and out. All right. So when there is no air moving in and out, then it only measures the elastance of the lung. That means elastic capacity. The lung is made of elastic tissue. If the rubber is too strong, then you won't be able to stretch it. So that is the elastance. Compliance is inversely proportional to your elastance. More the elastance, less is the compliance. Okay. So static compliance measures only the elastic properties of the lungs. Dynamic compliance, the word that again indicates, is when the lung is moving, when the air is going in and out. That is in normal clinical setting, when the baby is breathing. That is what we measure, is the dynamic compliance. If you see this figure, imagine the lung with springs. That is when you expand the spring, it comes back to the normal. That is the natural tendency of the lung, is to recoil back. Similarly, if you see the chest wall, if you expand when the inspiration, the chest wall moves out, and again it wants to come back, and the lung wants to come back inside. So there are two forces which are always acting against each other, but in a harmonious way. So how to measure compliance is change in lung volume per unit change in airway pressure, which is measured in ml per centimeter of water. That is pressure you apply. So a static PV curve, this is when the lung is stagnant. The total lung chest wall compliance comprises of the compliance of the lung and the chest wall. Remember, in preterms or in neonates, the chest wall is highly compliant, and the lung is very less compliant, which is primarily determined by its surface tension. All right. So if you see this figure, the one in the black line, you can see the chest wall compliance. It's almost parallel to your total lung capacity. So the chest wall is highly compliant due to pliable ribs and weak muscles. Even during inspiration, you will see a paradoxical inward going of the chest wall, okay? And if you see the red line, it is the lung compliance, which is lesser than that of chest. The next component which we need to know before going to the loops is the resistance. Resistance we all know, but what does that mean? Is the impedance to the flow of gas. Any friction to the flow of gas is called resistance. Two types of resistance which we need to know clinically is airway resistance, that is any impedance to the flow of air inside the tracheobronchial tree is the airway resistance. Second one is called viscous resistance. This is the resistance generated due to movement of the tissues against each other, okay? Most of the times it's the airway resistance which causes problem, okay? If you see neonates, look at the staggering amount of resistance offered by the upper airway itself. It's about 70%. 60% is by the nares and 10% is by the glottis. So that's quite a huge amount. We all know, the anatomy of the preterms and how narrow the airway is, which I'm going to tell in the next slides. 20% is by the distal airways, the proximal and the distal airways. You can see, look at this figure. As we go down, how the resistance drastically comes down from trachea, bronchus and bronchioles. Most of the resistance is before the bronchus. As we go down, it comes down. Why it comes down is because the surface area is so tremendous compared to the body weight that there is hardly any resistance down the lungs. How do we measure resistance? Is change in its amount of pressure, the pressure gradient required to move the air in and out at a constant flow rate. Okay, it is measured as centimeter of water per liter per second. What are the two most important determinants of resistance? We all know from physics, which we have read quite a lot. How do we apply it in our cohort? Is Poiseuille's law, which is resistance is directly proportional to the viscosity, length, and inversely proportional to the radius. The diameter of the preterm or a neonatal airway is almost 1/4 that of an adult. So if you put the radius as 1/4, your resistance automatically increases to 16 times. Okay, and then Reynolds number is another terminology which we need to know. Is 2 multiplies the density, radius, and velocity by viscosity. It determines whether your airflow is turbulent or laminar flow. Okay, laminar flow. So if your number is more than 2000, then it is most likely to be turbulent. If you see these 4 figures, the first 2 figure is the one with surfactant. Look at the amount of pressure. This is the line, the pressure required to open up this alveoli. All right, it's very less. Why? Because the surface tension is very low. Surface tension, the amount of pressure required to open up is directly proportional to surface tension and inversely proportional to the radius. What happens if your radius is reduced by 1/4? Automatically, the pressure required to open up this alveoli increases by about 16 times due to increase in resistance. Okay, how do we apply that clinically in the preterm babies? So we all know this formula now. Resistance is directly proportional to the viscosity, again a length, and inversely proportional to the 4th power of radius. So premature babies, we all know we intubate usually with 2.5 and 3 mm ET tube, and the ventilator flow rates are usually 8 to 10 liters. Okay, so when you provide a flow rate of 8 to 10 liters, look at here, the Reynolds number is directly proportional to the velocity. So if you increase the velocity, the turbulence increases in this narrow diameter. So obviously you'll be increasing the turbulence by about 30 to 40%. At the same time, if you reduce the length of the ET tube from 14.5 to about 7 centimeters, as resistance is directly proportional to the length, if you reduce the length, you'd reduce the resistance by about 50%. That is how the applied physiology comes into play. What do we do with noting? We have been reading compliance resistance since a long time. So how do we apply it clinically? Okay, so the compliance, normal compliance in any lung would be 1.5 to 2 ml. In neonatal cohort I'm talking about is 1.5 to 2 ml per centimeter of water per kilo. All right. If you see on the right hand side of your screen is the compliance and resistance based on the gestational age and the birth weight. as you can see, the compliance increases gradually as the weight increases and the resistance comes down. Okay, normal resistance in a static lung in ideal conditions would be about 20 to 30 centimeters of water per liter per second. All right, so if you take certain diseases in newborns, mainly which we are dealing with is RDS here in the preterm cohort, would be mainly its reduced compliance. However, the resistance remains normal. Okay, so why the implications will be rapid rate and atelectasis, I'll tell you. And BPD mostly. Okay, again, it is a disorder of compliance, and there will be increase in resistance as well. The next terminology which we need to know is about work of breathing, which is the force required to move the air in and out of the lungs. And the time required to move the air in and out of the lungs will be your time constant. Okay, so it's as simple. Lungs mostly, the work of breathing goes in overcoming the elastance of the lung. So when you breathe in, you have to overcome, the air is flowing in, so you have to overcome the elastance of the lungs as well as the resistance. Okay, so mostly the energy goes in overcoming the elastic force, and 1/3 is by the resistive force. That's why the work of breathing is delta V, change in volume multiplies change in pressure. Okay, and how this area under the curve implies work of breathing. Okay, if you don't know this curve, I'm going to talk in the next slide. So this is the dynamic PV loop, which we have seen already, the static PV loop. All right, the compliance of the chest wall and the lungs. What is this dynamic PV loop? Okay, if you plot the lung volume, that is volume above the functional residual capacity against the intrapleural pressure. So when you breathe, all right, this is the elastance. If you take, it's color coded here. When you breathe, this is the inspiratory curve, this is the expiratory curve, and the central line is the line of compliance. That means when there is no resistance at all. Okay, if you were to negate the resistance, then you get a compliance line like this. So the one in green color is the resistive inspiratory work, the resistance required to overcome during inspiration. And this dark purple one is the resistance required to overcome during expiration. All right, and this triangle says is the elastic, the resistance required to overcome the elastance of the lung. So when you multiply the delta P and delta V, then you get the work of breathing. We daily use this terminologies like work of breathing. There is increased work of breathing for this baby. So that is what it means. And it can be calculated, delta V by delta P. Delta V multiplies delta P. Okay. Look at this compliance, the normal compliance of the lungs. If the lung is very compliant, you could get this kind of curve during inspiration, and during expiration, this is also called hysteresis. And in an RDS lung, you can see how the curve is touching to the baseline. So when you see the inspiratory, the resistance is hardly any. If you say the resistance during the inspiratory work, okay, is hardly any. But look at the compliance. So I look at the work to overcome the elastance. Okay, that is the compliance is very, very poor. So when you apply this compliance and resistance, when we know what is compliance, when we know what is resistance, we need to apply it clinically so that we make use of it. What does that mean? First is, if you take, this is the static curve, when you superimpose it on the dynamic curve. Okay, these are the dynamic curve. What happens in RDS? We all know the vertical limb is the change in volume, which is very, very less, but the amount of pressure required to increase it is very huge. All right. So that is in RDS, we know it is due to low compliance. What happens when you apply Cpap or continuous distending pressure? Sorry. What happens when you increase the pressure, apply the Cpap, is look at the vertical limb here. There's much increase in the volume for a little increase in pressure. So your lung becomes almost like normal. The FRC increases here. Okay, after applying the CDP. What happens when you continue or over distend the lung? Again, the vertical limb reduces here. So the amount of pressure required to get this would be get this volume change would be less. Exception is only one case, when BPD, where there is overinflation, but this is due to the airway collapse. So when you apply a continuous distending pressure, you take out the stored air and then take it out and bring the curve towards a little bit normal. So the only exception would be BPD and meconium aspiration syndrome. Time constant, I've already told you, the force required to take the air in and out of lungs is your work of breathing. and the time required to take the air in and out of the lungs is your time constant. Okay, it is the compliance multiplies your resistance. You can see, for instance, the change in for example, it takes about 63 percentage of air to go in about one time constant, and one time constant is 0.15 seconds. And by about 3 time constant, you would fill your lungs or empty your lungs 95%. Okay, time constant, of course, are very important in clinical settings, especially in premise, because the time constant is short, the rate is high. Time constant depends upon the size of the body and the size of the lung. So if it's an elephant, the time constant would be very much, and however, the rates are slow, like in adults. Whereas that in premise, the time constant is short, but the rates are high. This is most important essential knowledge which we need to know to set the ventilator. Clinically, application is when you apply it clinically. In RDS, I've already told that the compliance is less, but the resistance is normal. So we can get a short I time here. It can be as short as 0.05 seconds in severe RDS in extreme premature babies. If you take babies with MAS and with BPD, they have increased resistance, as well as there is decreased compliance as well. So there is a longer I time to throw the air out. Okay. Therefore, they are more at risk of inadvertent PEEP. Okay. And ventilation with less rates and long I time is the basic need in those babies. So when you sum up the physiology, this would be the best diagram, I would say, is how these neonates are at of mechanical disadvantage and what we need to know. Not confusing with many things here. If this is a neonate, if you see the lungs, they have low FRCs, okay, which we all know they have low functional residual capacity. Okay, that means the air which remains in the lung after normal expiration, whatever air remains in the lungs is your functional residual capacity. However, the neonates have very low residual capacity. They need to maintain that so that the FRC doesn't fall below the residual volume or closing volume. So they use 3 mechanisms, which we need to remember to maintain the FRC. They use 3 mechanisms. The first one is expiratory break, the laryngeal breaking. We call it expiratory breaking of the glottis, or also called as laryngeal breaking. Okay. This comes closer together during expiration so that excess amount of air will not go out. That is how you get your grunting. Okay, that is compensated by increase in respiratory rate. Okay, that is shorter I times. Another important thing which we need to know in babies is they sleep most of the times, which we all know, and they are REM sleeps. During REM sleep, there is a tonic inhibition of the diaphragm and the intercostal muscles, even during inspiration and expiration. So when this happens, the chest wall will not be able to throw the air out of the lungs completely. Okay, that is how they maintain the FRC. There are 3 mechanisms which they maintain: is the laryngeal breaking, high respiratory rate, and inhibition of intercostal muscles. Okay, so that they can maintain the FRC and prevent the lung from collapse. We all know the heat loss and increased metabolic demand. We say that newborns have large surface area, so their oxygen the oxygen demand increases because of increased respiratory rate. To maintain the body temperature, so oxygen consumption automatically goes up about 7 to 8 ml per kg per minute, which in adults is about 1 to 2 ml per kilo per minute. Okay, and then the compliant chest wall, which I've already spoken about. The last one is surfactant deficiency, is a major factor which determines the compliance in newborns. Okay, to sum up, this would be the slide. Whatever I've spoken about the compliance and resistance, we need to know this to move on to our next half of the topic, which is HFNC. Okay, so we all know that airway resistance is narrow, so it increases the resistance. Surfactant deficiency decreases the compliance. High respiratory rate, short I times. Okay, so the next of the half of the topic is heated humidified high flow nasal cannula. I think this topic should come after the NIV, but I'll try not to touch SRINIVAS sir topics. So heated humidified high flow nasal cannula. So what happened when Cpap was used used tremendously all over, then people started having the problems with Cpap, especially the nasal injuries. Then they didn't have an alternative, so they started using low nasal cannula, the simple nasal cannula, at an higher rates. But the problem with that is the air was not humidified, not heated. So that caused a dryness and it decreases the lung compliance, and they weren't successful. So then neonatologists started, thinking about what if we humidify and heat the air to about room temperature or even to the body temperature of the baby. So these are small, thin, tapered, that's how HFNC came into existence. So HFNC are a small, thin, tapered binasal tubes that deliver oxygen or blended oxygen and air at more than 2 liters per minute. Okay. However, some studies have even used 1 liter, more than 1 liter per minute, but the standard definitions are anything more than 2 liters per minute, 2 or more than 2 liters per minute. They'll fit in the nostrils, but they fit very loose. This is the most important. The primary success of HFNC depends upon heating it to 37 degrees Celsius and humidifying it to about 100 degree. Okay, 100%, sorry. So humidity and heating is very, very important. That's what the name derives from, is heated, humidified, high flow nasal cannula. High flow because you are giving a flow which is above, which you can give in low flow, that is 2 liters. It gives Cpap, but it's not constant. It's a variable Cpap, and you can't measure it in HFNC. That's one of the disadvantage. Cpap depends on various factors. First is size of the baby, the prongs, breathing pattern, nasal secretions, and if the mouth is open or closed. If the mouth is open, then the Cpap pressure goes very high. Again, it's a flow dependent. The oxygen tension raises until a particular flow, after which there is a plateau effect. All right. After this, you cannot increase the oxygenation. There is a great intra and inter-patient variation in this. If you're using an HFNC, there is great intra and inter-patient variation in the pressure generated, the Cpap pressures. That's what I told. It's very variable, and you can measure it either. Distending pressures are not uniform and vary depending upon the size of cannula. So how do they act? So we know what is HFNC. We need to know how do they act. First is they warm and humidify the gas. Remember, even a brief amount of gas at room temperature would decrease the lung compliance and conductance. So you have to heat it to about 34 to 37 degrees Celsius and humidify it to about 100%. So that is how the success rate depends on. So this is a warm humidified gas which improves the pulmonary compliance and conductance compared to the dry cool gas. Very important. The second one is it decreases the metabolic demand. So when you are already providing a gas which is heated to the body temperature and humidified, the infant need not use the energies or burn the calories to do so. So in that way, you'll help by reducing the metabolic demand in infants, which I've told you is about 7 to 8 ml per kilo per minute. Third is it decreases the inspiratory resistance. You are using a high flow. Okay. How much flow? I'm going to talk. It's about 2 to 8 liters you are using. So it decreases the inspiratory resistance associated with nasopharynx. We all know the upper airway itself contributes to about 60 to 70% of the resistance in newborns. So it decreases that resistance associated with nasopharynx and thus reduces the work of breathing. Fourth is when you are providing that much of flow rate, it would reduce your dead space also and helps in clearing out the carbon dioxide. Lastly, it does provide a Cpap. Let's see how much of Cpap it provides at what rates. Okay, how do we provide HFNC? Standard nasal cannulas can we provide? Yes, it initially began with that. However, it's not the standard because it's not humidified, it's not heated, so it's outdated. You can't provide any flow rate more than 2 liters in the low flow nasal cannulas. Vapotherm, I'll start with Fisher and Paykel OptiFlow. I think most of us have used it. This is how it looks. Fisher and Paykel OptiFlow Junior. The set would be pretty much like Cpap set, except that it doesn't have an expiratory limb. So you will have only the inspiratory limb in HFNC, and you will have, this is the cannula, HFNC cannula by Fisher and Paykel. It's called OptiFlow Junior. The nares, if you see the interface here, the interface is very peculiar that it is tapered. It is a tapered interface. Okay, it tapers and they are very small. They are very soft. That is how it has a advantage over others. Okay, so Fisher Paykel, the flow rate can be anywhere from 1 to 60. However, in neonates, more than 8 liters is not recommended at all. Humidity and gas temperature. Humidity is about 100%, and gas temperature, it is about 34 to 37 degrees Celsius. I think, sorry for this error. Vapotherm, again, you can provide, it looks like this. This is the equipment. This is again a standard equipment to provide the HFNC. You can adjust the flow rate anywhere from 5 to 40 liters, humidified to 34 to 37 degrees Celsius, and heat to about 37 degrees Celsius. Okay, so you can provide it 5 to 40 liters. Again, beyond 8 liters, it's not recommended. How do we apply the interface? You can see two diagrams here. One is very tightly fitting here. That means there is no gap here, and there is a lot of gap. Okay, so we need to maintain a lot of gap. Why do we maintain a lot of gap? Okay, so these are the do's and don'ts which we need to remember while using HFNC. First of all is the prong should never cover more than 80% of the nasal orifice. Okay, cannula to nair ratio should never exceed 80%, and most of the times it is around 50%. Okay, the prong should never ever cover beyond 80%. That's the maximum recommended. Beyond that, you can't. Never close the mouth while giving HFNC, because the amount of pressure generated, the Cpap generated, is very variable. Should never close the mouth while giving HFNC. Always put an OG tube in situ so that excess air comes out from the, and there isn't any gastric distension. Monitor the infant when you increase the flow or decrease the flow as per protocol, especially if you're increasing the flow. Do not go the flow rate beyond 8 liters. And if FiO2 is above 40%, I think Cpap is not helping. I mean, HFNC is not helping. So we need to think of other modes. Okay. This is the other interference which we all have read and been using as well, is Ram's cannula. Is pretty much like your OptiFlow. However, the nasal interface here, these are not tapered, and it's a little bit harder compared to your OptiFlow Junior. It is again color coded. Infant more than 2.5 kg is about orange, and 1 to 2.5 is blue. Anything below that, Ram's cannula, I think it's hard to use because of high failure rate. So probably these are the two most important colors which we use. So pros and cons of HFNC. The advantages are it's very simple to use. It reduces the work of breathing by all the mechanisms which I've told you. And patient compliance is very good. Okay, acceptance is very good as well. Okay, the disadvantage is it is unmeasured and variable PEEP. Because you are giving at a high rate, you are the gastric distension and perforation rates, there no evidence as such. However, gastric distension is more. Possibility of lung over distension. We'll see how, what's the evidence beyond for that as well. Okay. If you see two mechanisms, I mean two equipments which I've shown you, Vapotherm and Fisher Paykel, and the amount of Cpap they deliver is quite variable from 2 liters to 8 liters. The amount of Cpap delivered varies anywhere from about 1 to 6 at a rate of 2 liters per minute. At a rate of 8 liters per minute, the amount of Cpap pressure delivered would be anywhere variable from 1 to 9. So it's quite variable. So you will be worried if you are delivering the Cpap of 9, isn't it? So the variable pressure, and there isn't any thing you can measure it by clinically, routinely in the neonatal unit. So it's always hard, whereas in Cpap you can measure it. So that's again a disadvantage of HFNC. Serious incidents apart from gastric distension, pneumothorax and stuff is scalp emphysema. If you increase the rate, this has been seen if you increase beyond 8 liters. However, these are case reports, but still can be possible when you provide an air, especially in extreme preemies who are less than 1 kilo, possible that there could be pneumoorbitis and pneumocephalus as well. However, they are very, very rare. One caveat which we need to remember is attention should be taken to about the size of the prongs. It is only by the recommended use as recommended by the manufacturers, and keep a gap between the nasal orifice and the interface. Okay, indications straight away simple. We'll know what is the evidence for that as well. Post extubation more than or equal to 28 weeks of gestation. Stable infants on Cpap, nasal injury, and if you are having a nasal injury secondary to Cpap, and recommencing respiratory support after weaning from Cpap. Okay, these are simple indications. Initiation of weaning, you initiate at a flow rate of nearly about 4 to 8, some starts with 6 to 8 liters. FiO2 would be 21 to 30%. Temperature and humidity remains the same. So once the baby gets stabilized, okay, you can increase the FiO2 depending upon your target oxygen saturation and signs of whatever scoring we use. SOS or Downey scoring. So based on that, you stabilize the infant. Once the infant is stabilized by about 24 hours, you start weaning. Okay, you wean about 0.5 to 1 liters when they FiO2 about 21%. You reduce the FiO2 to about 21%, and then start weaning 0.5 to 1 liters per minute. 1 liter every 4 to 6 hours, depending upon and the monitoring and the blood gases. Okay, so that's simple initiation and weaning strategy. However, make sure that you do not increase the flow beyond 8 liters. So a few slides on the evidence. How does the evidence, I would categorize it, is before 2016 and after 2016. Why is that? Because when you do a thorough search strategy, this was one of the study in 2011. Look at the amount of publications on Cpap is about 250, and HFNC were very, very few, you know, and the next other NIVs are even lesser. So HFNC is very, very less. Okay, when I did a thorough strategy on this, you would see about 239 results. However, when you screen and delete most of them, you would find about 40 to 50 studies on HFNC, about 20 odd randomized control trials. All right, so this is after 2016. So let's have a look before 2016. This is a Cochrane which was published in 2016, high flow nasal cannula for respiratory support in preterm infants. Let's dig a little bit in detail about this. What does preterm, what did they do in this Cochrane? Is they studied all preterms who were less than 37 weeks, heated humidified who had got the intervention as HFNC, more than 1 liter per minute. For this Cochrane, they have used this definition, compared with low flow nasal cannula, Cpap or NIPPV. Outcome would be death or CLD. Okay, so they measured this. Secondary outcomes would be intubation within 7 days or treatment failure. So what did they find? Is HFNC any better to CPAP? As a primary mode. What do you mean by primary mode? Is if you use as a primary support and secondary support. Primary support is if you use at birth or within first 2 hours. Okay, that's primary support. You're using it as an initial mode of support for the babies. Secondary is if you're using post-extubation or post-weaning from CPAP, if you're using, that is your secondary support. So what did they find when they compared HFNC versus CPAP as primary mode? 4 RCTs where they found out nearly 439 in babies. Primary outcome, which was death or CLD or death CLD, there was no difference. Okay, secondary outcome, again, there wasn't any difference except for increased duration of respiratory support in one study. So before 2016, HFNC or CPAP would be the same in babies above, less than 37 weeks. However, one important thing which we need to know, there were no extreme preterms in these 4 RCTs, less than 28 weeks. Okay, this is the forest plot, which clearly states the net effect crossing the midline, crossing the center. So, and there isn't any much heterogeneity among the studies as well. So yeah, what happens when HFNC was compared to CPAP as a secondary mode to prevent extubation failure? Again, 6 RCTs they had, there was no difference between the primary and secondary outcome. Nearly about 1,000 babies were involved. So there was hardly any difference between primary and secondary outcome. HFNC would decrease the incidence of nasal trauma, which was statistically significant. However, air leaks also, there was a significant decrease in incidence of air leaks, but the confidence interval was crossing unity. But still, we all know clinically when we use HFNC, there is less amount of nasal trauma to the babies. So yeah. What happens when you use HFNC for weaning from CPAP? HFNC compared with continued CPAP. Continued CPAP means, for example, if you're using CPAP for babies, for a longer time on a very low settings of CPAP, when you switch them to HFNC, there isn't any much difference. However, HFNC groups babies tend to use a longer, oxygen therapy and longer days of respiratory support. Okay, and this again involves the babies who are more than 28 weeks. So if you use HFNC in a baby who's about 28 weeks for weaning from CPAP, you might end up giving longer duration of oxygen therapy and longer respiratory support. HFNC versus NIPPV as a primary mode, again, there was no difference, only 1 RCT though, 76 babies recruited. Mean gestation was a bit higher, so probably that's one of the factor. There is no difference between primary and secondary outcome, but this was a pilot study and very underpowered. So, to apply this clinically, it's very difficult. Alternative modes of HFNC to prevent extubation, if you compare Fisher Paykel versus Vapotherm, there is no significant difference. If you use humidified versus non-humidified HFNC, I think we should not consider this because nasal mucosal scores were not available in the studies. It does say that there is no difference, but we know we should not use non-humidified and non-heated, HFNC. So HFNC until 2016 is a nutshell, similar rates of efficacy to other forms of non-invasive respiratory support, especially Cpap, but this is limited only to the babies who are more than 28 weeks. Most evidence is available as post-extubation support. Less babies were studied in less than 28 weeks and less than 1,000 grams. Okay. So what happened after 2016 is the RCTs came into existence. 5 RCTs. One of them is an Indian study. I'll talk in a little bit about that as well. HFNC is a primary support for respiratory distress in preterm babies. Secondary support, I did find 3 RCTs, which compared HFNC post-extubation with Cpap. And again, these babies involved babies who were more than 28 weeks and more than 1,000 grams. Okay, these were the 5 RCTs. The first one was from the US, which was published in JAMA, HFNC, and most of them were non-inferiority trials. All right, this was published in 2016. A month later, then we got the HIPSTER trial, which was published again in NEJM from the Australian group. Then Korean journal has also published. This is one of the study from Murthy et al. From Hyderabad, was published a study which is pretty similar like HIPSTER. The methodology were pretty similar like HIPSTER. And one recently in 2019 from the US, again published in American Journal of Perinatology. So if you combine the evidence for all these 5 RCTs, I put it in a simple way. See, if you see the patient cohort, what they recruited is most of them are about 28 weeks, all right, and more than 1,000 grams. So the first study was they published in JAMA. The more than 28 weeks, about 300 babies, 300 odd babies were recruited. The outcome was there was no difference between HFNC and Cpap when they compared as a non-inferiority trial. So HFNC was non-inferior to the Cpap. However, the amount of surfactant used in these babies, about 40% of the babies got surfactant. So that could be one of the reasons for their success. Second came the HIPSTER trial, that is HFNC as a primary support in neonatal respiratory distress. The outcome results were 25% versus 30%, 25% failure rate in HFNC versus 13% failure rate in Cpap. And this trial was stopped early because of clinical significant failures in HFNC. Similarly, the Murthy et al. Study from neonatology, published in Neonatology from India, did find the similar results as that of HIPSTER trial, 26.3% versus 7.9%. It was clearly statistically significant. So these trials were stopped early because of the clinical significance failure rate in HFNC group. The other 2 studies, their mean gestation was a little bit higher. So probably the success rates were higher in those cases, and there was no significant difference between that. Otherwise, the intervention, comparison, and outcome, pretty much same in all the 3 studies. What happened when you use HFNC in babies who were less than 1 kilos and less than 28 weeks? This is one of the retrospective study from Philadelphia, US. So a retrospective data analysis which showed over a period of 5 years what happens when you use HFNC in babies who are less than 1,000 grams. You can see here the failure rate, the primary outcome of BPD or death would be much higher than in compared to Cpap groups. When you see detailed analysis of this Cpap and HFNC, look at the BPD rate, in this is about 42.2% as compared to HFNC, which is 52.2%. And the days to room air, the median would be 62 days in Cpap group as compared to 76 days, with IQR ranging anywhere from 50 to 103. So it's quite high. After logistic regression, you get these numbers. So less than 28 weeks or less than 1,000 grams, it didn't really help. Okay, and there is no evidence as such. HFNC, when you use it in special care nurseries, that is KUBU, what happened? This was again published exactly a year back. Multi-center randomized control trial, which is again a non-inferiority trial. The patient cohort was more than 31 weeks and more than 1,200 grams. Used the intervention as HFNC compared with Cpap against the treatment failure. 754 babies were involved. Look at this mean birth weight. It's 2.9 kilos and mean gestation is 36.9. yet you had a failure, HFNC group of 20.5% versus 10.2% in CPAP group. So even in special care unit, in higher babies also, if you use as a primary mode, you tend to fail more often than not if you're using HFNC. The incidence of mechanical ventilation, although was not difference, and the need to transfer to level 3 was not a difference. When you sum up the evidence until 29 from 2016, this is one of the unpublished data from one of the conference papers which I've got. So there were 21 randomized control trials involving 3,200 babies. Most of them were again more than 28 weeks and more than 1,000 grams. So the conclusion of this meta-analysis would be, if used as a primary support more than 28 weeks, when used after in-short treatment, the risk of treatment failure there is no difference between treatment failure. I mean, between the failure rates between HFNC and CPAP, if you use it after in-short. More than 28 weeks after in-short, the treatment failure, there is no difference between HFNC and CPAP. Prior to in-short, CPAP is still the best mode. Secondary support, there is no difference in the rates of re-intubation, post-extubation. If you use HFNC or CPAP, it's fine. However, if you use it in babies, again, less than 28 weeks, you would tend to fail more often than not. So I put it very easily for you to understand. If as a primary support, if you use HFNC less than 28 weeks, less than 1,000 grams, if you have performed in-shore or not in-shore, it's not yet the best mode. So we shouldn't be using that. More than or equal to 28 weeks, more than 1,000 grams, if you have performed in-shore, then a definite tick. But if you're not performed in-shore, then you may or may not use, depending upon the unit policies. However, there is depend upon the unit policies whether you are comfortable in using it. There is no robust evidence as such, okay, until 2019. So if you're performed in-shore, the chances of success is more. HFNC is a secondary support, less than 28 weeks, less than 1,000 grams. Weaning from ventilation, no, straight no. And if you're weaning from a low setting CPAP, yes, because you have no statistical significance between HFNC and CPAP. More than 28 weeks, more than 1,000 grams, if you're weaning from IMV, a definite yes. Weaning from nasal CPAP, a definite yes. So less than 28 weeks, less than 1,000 grams, a clear no. HFNC and the incidence of nasal trauma, it's very less. Sorry, I'll not take more than 2 slides again. It's very less. The incidence, you can see the forest plot, which is crossing on the left. So the incidence of nasal trauma is very less. However, there is a lot of heterogeneity among the studies. Air leaks, we have already seen it's less, but it's not statistically significant between CPAP and HFNC. So you might have lower incidences, but they may not be statistically significant. HFNC and physiological instability. On HFNC, your heart rate and respiratory rate might be a little higher compared to the CPAP. So this is one of the study from 2018. Pain perception. This is again the study which compared the HFNC nasal CPAP and nasal cannula. HFNC, I mean. Nasal CPAP, the PIPP scores were ranging up to 10 to 12 compared to the nasal cannula, which were on lower side. When compared to the salivary cortisol levels, that is the stress levels, which were compared higher in CPAP compared to the nasal cannula. So the stress levels would be a little lesser. Time to reach full feeds, again, there are not many studies. I could find this one a good study. It's a single center RCTs. The mean time to achieve full oral feeding in HFNC is 36.5 days compared to nasal PPAP is about 34 days. So there is hardly any difference between HFNC and CPAPs, which offer no added advantage. Cost effectiveness, again, because if you're using less than 28 weeks, you tend to fail and you end up using a CPAP again. So as a sole primary support, if you're using CPAP, if you're using respiratory support, CPAP is likely to be cost effective compared with high flow. And during transport, if you're using HFNC, again, there are hardly any studies in this. This is one of the preliminary study from East of England involving 31 neonates, mean birth weight of 33 weeks. So if you're using in emergencies more than 1 kg, you can use it. However, the safety profile is not mentioned here. They tend to be safe and feasible if you are more than 1.2 kgs and using in elective transports. Up to flow rate of 6 liters per minute is feasible during transport. Above that, you can end up having failure if the FiO2 is going high. If more than 40%, it's safe to intubate and transport the babies rather than bringing them on HFNC. Less than 1 kg, please avoid using. So again, the comfort of using, ease of using, this is one of the studies, same by the Hipster group, which did the survey nursing teams. We showed that HFNC offered, most of them strongly agreed that it is more comfortable in infants, causes less nasal trauma, and parents prefer to use it. All right. So comfortable wise, HFNC supersedes CPAP. So sorry to overshoot my time. Just the take-home message from this would be preterm would not be, they are not same as term infants, and term infants are not same as small children. Knowledge of applied physiology is important before we deal with premise. NIV, unarguably the best mode of RDS. The next speaker is going to tell you, which NIV and, make the debate more interesting. HFNC is simple to use. However, simple is not always safer. HFNC has a primary support used in babies more than 28 weeks, more than 1,000 grams in mild to moderate RDS. In severe RDS, you might end up, failing it. So preferably use after ensure. Caution, again, high failure rates. HFNC is a secondary support. Post-extubation, tolerated better in babies about 28 weeks. Less than 28 weeks at this point of time, I would say no. So thank you. This was my presentation, and thanks NNF Karnataka for giving this opportunity, and apologies for overshooting my time.
Yeah. Thank you, Dr. SHANKAR. It was a wonderful presentation. I'm sure you'll have a lot of questions, and you have covered most of it very comprehensively. So moving on to the next topic, I request Dr. SRINIVAS sir to start the next presentation. And once this presentation is done, we will take up the discussion part, and Dr. Shashidhar will be moderating the session. I request all the participants to kindly pose the questions if you have. Thank you. Over to you, SRINIVAS sir.
Thank you so much, Prashant. I think I really congratulate Dr. Shiv because it was one of the succinct presentation that I have heard. And the other reason why I wanted to congratulate is it has made my work a lot more easier. He really explained it so well. Thank you so much, sir.
Thank you so much, sir.
Yeah, let us start with the NIV. I think this session, particularly on NIV, was very much designed to give a bit more wider overview of what we think about non-invasive ventilation, what are the understandings that we have, what are the confusions we have, how we need to look into it in its perspective. And there are many neonatologists in this group who are more experienced than me. So if you think that my presentation is a little bit basic or primitive, please help me to improve that one. I'm very much open for it. So let us start. And the disclosure is it's a scientific activity, and I'm declaring there is no conflict of interest. Okay, let us start. Because this was the topic, that is non-invasive ventilation, and there's a lot of things that has been talked about non-invasive ventilation. So I thought that I will put that one as a introduction slide. Then we will take it from there onwards. And I want to tell you that this slide is going to repeat later as well. So let us know what we understand about non-invasive ventilation, how it has to be classified. So if you take the respiratory support as a whole, then if you are putting an ET tube, then it is called as invasive ventilation. If you do not put an ET tube and give a respiratory support, it is called as non-invasive ventilation. If you put an ET tube and give positive pressure ventilation, it is called as invasive IPPV. And good old days, we would use ET CPAP, like put an ET tube, a little bit short one, and then give CPAP through it. But I'm sure that it is now abandoned practice. I don't think anybody is practicing that anymore. So I think we'll just leave it that way. And anything which is a support which is given without an ET tube is called non-invasive. But please concentrate here, right? It is easy for us to know what is non-invasive because there's no ET tube. But there is two different sections here. One is a positive pressure ventilation, which is given via various means, but not putting ET tube. There are other methods of giving respiratory support where we actually don't give positive pressure ventilation, but still we use the term NIV or non-invasive ventilation very easily. So I would request all of you to concentrate on this. There is a big reason for us to worry about this classification, because most of us tend to mix both of them because they come under the same heading. Right. So with this preamble, I would like to start my presentation today. The learning objectives are very, So I want to cover something about normal breathings, mechanics and control, which has already been covered. Probably I will take 2 or 3 slides for it. And also similarly for pathological basis for why we need to ventilate a child. And particularly I'm concentrating on babies with a collapsed lung or atelectatic lung rather than the obstructed lung. And what are the various non-invasive modes. And unlike Dr. Shiv, who gave a very extensive, elaborative information about high flow nasal cannula, I'm not going to deliberate very in detail about any of these modes, but I'm going to tell why these modes are different from the other ones and what we need to really look into. Invasive mode, obviously we need, because we need to compare that with the non-invasive, and what are the similarities and differences between CPAP and IV, IPPV, etc. And what are the evidences for NIPPVs, and what is the knowledge gap we have, and what should we do in future. I don't know how to put this one right. And then, okay, just go through this animated cartoon. It is very, actually it's a replication of what Dr. Shiv has told. Basically, it's a normal tidal breathing, which is initiated by a natural process. And then there is a physiological control, which is the Herring-Brewer reflex. And I would like you to concentrate on the last bullet, that is the negative pressure is the driving pressure. In other words, the negative pressure which is created in the intrapleural space is the one which will drive the gas into the lungs. So let us emphasize on this. A negative pressure which is created in the pleural space or the intrapleural space drives the gas into the lungs. So that is the driving pressure. And if you put a graph for that, you can see like this. So there is a negative pressure, and then it equilibrates, then and during the expiration it becomes positive. I think all these things has been already explained. So please keep this cartoon in mind, because it is very much needed for us to compare with the rest of the things. Now coming to compliance curve, which has been well detailed in the previous session, I would just like you to go through this animated cartoon, which shows what happens to a lung which is small, which is partially open, and which is over-distended. For a given unit rise in pressure, the amount of volume that is gained in a very collapsed lung is minimal. That means to say it has a very low compliance. That is why it sort of stays on the lower part of the compliance curve. Whereas a lung or the alveoli which is partially expanded really gains much with that unit of pressure. That means to say work of breathing is very less. There is a lot of gain for the unit pressure in terms of volume. And again, if you see an over-distended lung, for example, if you give CPAP a higher degree, for example, 7 or 8, and result in over-distension, then the increment would be very minimal for a given unit of pressure. So this is very important for us to remember throughout. So what we need is, whenever we are talking about babies who needs respiratory support, our aim, particularly I'm talking about RDS and similar situations where it is an atelectatic lung, we need to keep the lung in this middle portion of the compliance curve, right? Right. So now watch these two animated cartoons. In the normal lung, if you see at the end of expiration, the alveoli is still open, and see the deflection here on the dial. That is the intrapleural pressure, which is going from negative to somewhere around 0. And that will result in a large gain in the volume. Compare this one with an atelectatic lung, which is very small to begin with, which needs a lot of work of breathing. You can see the movement of the dial here. So this is very, very important. Now we need to make this lung to come to this stage at the end of expiration, so that we can have this sort of work of breathing, which will be more helpful for the baby. Okay. So I have just again animated the same thing. Now our whole effort in giving CPAP or PEEP in the ventilator is pushing this lung to this stage, right? We can see by giving PEEP or the Cpap, we are just pushing the lung from this place to the middle portion of the compliance curve. I want to pause a little while here. The reason is when we say Cpap, again we are giving positive pressure from outside. That I agree. But the thing is, it is given only to inflate the lung and keep it inflated partially during the expiration. Even whatever the positive pressure that we are giving here to keep the lung open at the end of expiration is not driving the gas into the lungs. So this is not the driving pressure. Driving pressure is again the negative pressure created in the intrapleural space. So let us get it very, very clear about it. So the positive pressure or whatever we are giving in Cpap or P is just to boot the lung from the very collapsed state to a partially open state, and that's it. And rest of the breathing happens similar to what happens in the tidal breathing. So this is again the same similar animation. So what happens? You have an atelectatic lung, you give Cpap, then you end up in partially opening up, so work of breathing will reduce. But again, you see the deflections on the negative side. That means to say the driving pressure is the negative pressure created in the intrapleural space. Right, it is just the summarization of the same thing. I am impressing it so much because you will realize it later why I am very much particular about this. In a method of respiratory support like Cpap or even high flow nasal cannula or low flow nasal cannula, it is the negative pressure which drives the gas into the lungs. It is not the positive pressure given by the equipment. Now, let us see the same slide again. This is the first slide that I projected. So what is happening is we have a very different mechanism of gas flow into the lungs here, which is very similar to what happens with normal tidal breathing. And it is not the same with this part of the non-invasive ventilation. When you say NIPPV, SIPPV, or nasal flow, high flow ventilation, etc., then you are talking about an entirely different beast. Unfortunately, they are clubbed under the same heading because they just don't have the ET tube, right? So watch this one. I have 4 animated cartoons here, right? This is what happens with the ET tube in place, or even ET tube not in place, but a positive pressure is given by any mechanism like NIPPV or SIPPV. Just see, the air is thrown either from the middle of the trachea or from the nasopharynx, wherever it is, just to keep it open. But see the dial, it is always on the positive side. That is, the positive pressure that is given by the machine is the driving pressure, is the one which is going to drive the gas into the lungs. So in fact, if you see the way the gas flow mechanics or physics works, the flow is positive pressure ventilation. It is very similar to what happens with the IPPV, right? Compare this one with normal tidal breathing or even Cpap, which has a negative deflection to start with. So it is a mirror image effect, right? So in spite of this being under non-invasive, the way it behaves or the way it transfers the gas into the lungs is very much similar to the invasive positive pressure ventilation. Only thing is the place where it is delivered is a little bit different. So please have this this picture in your mind. That will help us to discuss it in a better way further. So when we talk about lung injury, we know about that electrotrauma, volume trauma, barotrauma, etc., all those things. But why it happens? Because we are giving the gas to the lungs via the motions. So let us compare this one with the normal breathing, where there is a negative deflection followed by positive deflection and vice versa in the positive pressure breathing. When I say positive pressure breathing, it includes IPPV and NIPPV as well, not the Cpap. Cpap belongs to this group. So here, the inspiration, cycling, and expiration, everything is patient controlled. Only thing is we are just supporting the lung to be more efficient. Whereas in this group, the inspiration, cycling, and expiration, all of them are clinician controlled. We all do with good intentions, but obviously it is not something which is natural. We do with our experiences, our instincts, and all those things. So this is the place we can actually injure the baby in the way inadvertently cause harm to the baby because we control all these things We assume that we are doing the best thing, probably we are, but still there is a lot of scope for lung injury in this way of breathing. So in that sense, the NIPPV belongs to this group and not this group when compared to CPAP, which belongs to this group. So why did we talk about NIPPV so passionately earlier is because we gave the positive pressure via nasal prongs or mask, and the circuit was very much the same as CPAP circuit. So there was a sort of feeling that we are almost giving CPAP. Though we have set all the ventilator settings like what we set with the invasive positive pressure ventilation, and the rate is generally kept a tad lower, around 20 to 25. And if it is needing more than that, probably it is better to go for ventilatory support. Some people may extend it up to 30, 35, but it's the sort of experience. But in our unit, we generally tend to keep it around 20 to 25. And if there is a lot of leak, the PIP or the delta P will be a little bit higher than what we keep for the invasive ventilation, because there's a lot of leak and not much gases sort of effectively entering the lungs. The typical settings that we use in our unit is a PIP of 18, a PIP of 5, and a rate of around 25 max. FiO2 is depending on the patient's need. But this setting is entirely individualistic, and there will be a lot of other people who are using very different settings, and they all have success with that. So I don't think that you need to keep this one in mind. Do with whatever is comfortable for you. But general thing is, the rate remains a little bit lower than the invasive pressure ventilation, and the PIP is a little bit higher because of the leaks. So what are the concerns that we have? It is not synchronized with the patient breathing efforts. And very similar to CPAP, you need to keep an orogastric tube to decompress the stomach. Otherwise, you have all the other issues associated with gastric distension. And nursing care is pretty much similar to CPAP. So this is how the NIPPV works. Let us see what the evidence says about NIPPV as a primary mode for RDS. In this study, which I think I have quoted really 4 studies on this, most of these studies had an objective of comparing NIPPV with nasal CPAP as primary mode, support mode in RDS. And outcome of interest is something which we need to keep in mind was, how can we prevent invasive ventilation? This is the gross, because if you think that invasive ventilation is bad to start with, then we end up in considering NIPPV as good because it is not invasive. But that's not true. And in these studies, both NIV and CPAP showed that they reduced the need for invasive mechanical ventilation, and the difference was not pretty different. So, in other words, the studies concluded that NIPPV can be used instead of CPAP to reduce the adverse effects of the invasive ventilation. But the concern that I have is, NIPPV itself is a positive pressure ventilation where the driving pressure is a positive pressure. So how can we say that it is better than invasive positive pressure ventilation in terms of reducing long-term adverse outcomes? And other important question is, if the babies can be managed on CPAP, then why do we need to administer positive pressure ventilation, which is definitely more harmful than the CPAP? So these are the questions that was not answered and the concern that I still have. But anyway, these are published in very reputed journals, and authors are very seasoned neonatologists. So it's not that I'm questioning their intention or integrity, but the thing is, these are the legitimate academic points that I wanted to raise. Then there were a few studies to see whether NIPPV can reduce apnea of prematurity. And you know what? They have considered only a short-term results of 4 to 6 hours to see whether the number of episodes of apnea is decreased when compared to NCPAP, that is nasal CPAP, and they showed that it does reduce. And it's not surprising because you are pumping the gas, so obviously the apneas recorded will be less. So that is something which we need to keep in mind, and it has been published. And the author's conclusion, or I think it is from the Cochrane that I have taken, is NIPPV may be useful in augmenting the beneficial effects of CPAP in preterm infants with apnea or frequent or severe. Probably they are trying to tell, in case if the NCPAP, nasal CPAP cannot be given because patient is having more and more apnea, you can try with NIPPV. I think I fairly agree with that point, because if you don't want to intubate and still give a little bit more pressure support than CPAP, this is fine. And then there is a few good studies of use of NIPPV in extubation failure. They wanted to see how many of them fail and go for reintubation. And the study showed that the NIPPV group had less reintubations when compared to CPAP, which is very much understandable because NIPPV itself is a positive pressure ventilation. And if you don't want to intubate and if you can manage with NIPPV, it's fair enough. So there is some evidence to say that NIPPV can help in decreasing need for reintubations. So this is one slide about synchronized NIPPV. It is very much like NIPPV except that it is synchronized, very similar to SIV on the invasive ventilation. But the studies done so far has shown that SNIPPV can be a bit more effective in reducing the instance of desaturation of bradycardia because it's very synchronized. But having said that, it is not very conclusive. This is a very small study which have reported that, but a couple of other studies have shown that not much statistically different results. So if you want to use an SNIPPV, you can. If you want to use an IPPV, you can. So there is not much of difference between those two. So I was discussing about this nasal IPPV versus endotracheal IPPV. That's an IPPV versus endotracheal IPPV, which was the point of contention. You can see the cartoon showing the gas being delivered to the lungs. That is a positive driving pressure in both of them. One being thrown from the top, the other being thrown from the middle of the trachea. So in other words, the respiratory mechanics are pretty much similar, except that there could be a lot of leak and there could be some loss of pressures in an IPPV. So this I think we have already discussed. Because we control everything in both of them, there is no plausible reason to believe that the NIPPV can be less harmful than the IPPV. I'm telling this one because all of us have an impression that NIV or NIPPV, because it is non-invasive, it is probably better than invasive IPPV, but particularly regarding to NIPPV, which has very similar gas flow mechanisms, that is not yet proved. There is no evidence to say that that is better than IPPV. Okay, so there are a few more things that I just wanted to share with you. Just concentrate on that first study, first one which I have quoted. They have randomly assigned the group to NIPPV or to oxygen by head box to prevent extubation failure. I think it was published in the Journal of Pediatrics, but I was really amazed to see how one could actually compare between these two, because oxygen by head box doesn't even give a little bit of support. So these are the studies that are sort of quoting that you can significantly reduce the reintubation if you use an IPPV. I agree with that, but I think this comparison is something to worry about. And there is another important trial. This was published very recently, probably 6-7 years ago. And this study included around more than 1,000 children or newborns. And actually, the authors set out to see whether NIPPV and nasal CPAP are different in terms of the long-term outcomes, such as death or bronchopulmonary dysplasia, which we are worried about. And in this study, they showed that both of them are not different. That means to say NIPPV is not different from CPAP. And it's important to note that in both the groups, NIPPV groups as well as CPAP group in this study, they failed and they were ventilated. That means to say the results that has been quoted by the authors or concluded by the authors is something which we need to rethink about, depending on the background, that 60%, closer to 60% in both the groups needed invasive mechanical ventilation. That means to say they would have had the same harmful effects of the invasive ventilation, and hence there is no difference. So even though it was a large study and the conclusion says that it's not better or less better than CPAP, it's very difficult to accept the results because of most of them needed invasive ventilation. So just to not conclude but summarize, there are some confusion about non-invasive ventilation because any form of respiratory support without an endotracheal tube is grouped under that heading non-invasive ventilation. And because they come under non-invasive ventilation, many of the authors or many of the studies and reviews, they include CPAP results with that of NIPPV results, and then claim that they are better than invasive positive pressure ventilation. So that is something which we need to tease out and find out whether they are really talking about a CPAP or something else. And most of the time it is in these studies, invasive, in other words, an endotracheal tube is blamed for all the outcomes or bad outcomes, and not the positive pressure that is causing the thing. So when we go through these studies, I think we need to concentrate on this stuff. So when I went through this presentation, or when I did this presentation, the articles I went through, I could group into two groups. The first type of article is they have a respiratory disease and they randomly allocate these babies to either NIPPV group or CPAP group. They find the outcome and then they conclude that nasal IPPV is better than invasive IPPV, either explicitly or implicitly. So this is something which is bit of a questionable thing, because they are comparing these two and then they are taking the results of invasive positive pressure ventilation in many other studies, and then they are comparing and telling that this is better than this. I think it is a bit of an over imagination, I would say. And there is another set of studies where they have given intubation and ventilation and then extubated, then they have randomized into NIPPV and CPAP group. They have shown that there are some short-term advantages like reducing the number of apneas or reducing the number of reintubations. However, these studies do not talk about results on PPD, IVH, neurodevelopmental or death, which is of very much importance for us. The one study which I quoted earlier did try to look into it, but as I said to you earlier, in both the groups, 60% of the neonates had invasive ventilation. So the question was, should we compare NIPPV with CPAP, because both of them are in the same group? I think we should not, because the respiratory mechanisms are different, and NIPPV will probably, even by theory part of it, have similar adverse effect as IPPV, and because the circuit is similar to CPAP, they can also have an added adverse effect of CPAP. So I would like to say that NIPPV is not simple CPAP with a rate, but it is rather than a invasive, not invasive, IPPV without a tube. So let us look at it in that way, so that will be helpful for us to make some management decisions. So currently we are doing a study in our ICU. We have just started. What we thought was, we will consider the babies with respiratory failure and we will give them CPAP. We consider SOP of more than 1.6 as CPAP failure, and compared to earlier studies which used multiple different types of endpoints for CPAP failure, now we have one currency, that is SOP, which I'm going to discuss in the next few slides. And then once they fail CPAP, then we will randomly allocate them to either NIPPV group or intubation group, and then we are going to look into the long-term outcome. We have just started. The result is yet to come. Probably it will take another year or so. Because I have mentioned about SOP, I will talk about that in a couple of minutes. This is a newly developed index to assess the severity of respiratory disease for babies who are on CPAP support. And our idea was to make sure that all of us speak in the uniform language, because when you put this baby on CPAP, depending on the progress of the disease, some people can go upon the FiO2 first, some people can go upon the CPAP pressure first, or some people can do alternative things, and before they call it as a failure, then they think, there are different cutoffs. Some hospitals use 7 and 60, and some people use 6 and 40, etc., etc. So in order to bring about the uniformity in the way we speak about it, this index was developed. So basically it is PEEP times FiO2 divided by SpO2. Make sure that SpO2 is measured when there's a good breath and not much of disturbance is there, because this is very prone to so much of errors. And in the initial study, what we did was, in the unit I was working, in the RDS, they were altering the PEEP more than the delta P. So I took the babies who were on mechanical ventilation, and I took only PEEP instead of MAP, and I calculated the SOAP index and compared with the oxygenation index, and we had a very good correlation of 94%. So this was initial proof of concept. Later on, we followed with another study where we took the babies who were on CPAP we measured the SOP index and ADO2, that is alveolar, So ADO2 was measured, that is alveolar arterial oxygen gradient, and we found the correlation was 84.7%. And in the same study, we took ADO2 of 70 as cutoff because this is a bad number. If you have ADO2 of 70, then 65% or out of 100 children who are ADO2 of 70, 65 will need mechanical ventilation. If it is 85, then 95% of them will need mechanical ventilation. If it is 100, all 100% will need mechanical ventilation. So we took that 2/3, like 70 as the cutoff. For that, SOP of 1.6 had a sensitivity of 0.8, that is 80%, and specificity of 90%. So still now we are using the same number in our unit to call Cpap failure. If the SOP increased to 1.6, then we change gears. That means to say we think that Cpap is not working anymore for this baby, and we have to increase the support. This was followed by another study where we validated SOP. It is not published, and pretty much similar results, right? Pretty much similar results we have. That's why we are sticking on to the number 1.6. So before I close, one to consider an IPPV or SIPPV as a non-invasive mode. I'm not talking about Cpap. We all know Cpap is the mode of treatment for RDS to start with. And if we are planning to use an IPPV, I would use whenever the rates required on invasive pressure are less than 15, so that we can extubate and put him on an IPPV, so that we can give a little bit of side breaths. And in post-extubation, I would rather prefer to go for NIPPV if there is apneas rather than Cpap, because it is shown to reduce the number of reintubations. And we are hoping that our study will give a good result or something reasonable result. And if it shows that NIPPV has a similar outcome to conventional mechanical ventilation, the Cpap has failed, then why would we intubate? Rather, we would try with NIPPV before that. So this is for now. Thank you for patient listening, and let me know if there are any questions.
Thank you, sir. Hello.
Hello, can you hear me?
Yeah. Yeah. Thank you very much, sir.
Thank you so much for giving me the opportunity. It was a great opportunity to be with all of you. And honestly, I enjoyed Dr. Shiva's presentation like anything. He did a wonderful job.
Thank you, sir. It means a lot from you.
Yeah. So I request Dr. Shashi there. Dr. Shashi?
Yes, I am here.
Yeah. I request you to moderate the session. I request all the participants to raise the hands and pose the question. Dr. Shashi, over to you, Dr. Shashi.
Sure. So congratulations to both the speakers. I think it was an excellent respiratory symposium, non-invasive respiratory symposium, where we spoke right from physiology to the peak of non-invasive respiratory support and their limitations and how they work, and starting from SHIV's excellent briefing on physiology, which was very useful for both all the trainees, the postgraduate fellows, and to all revision for all our faculty also. So, and Dr. SRINIVAS again spoke from his own experience and data. So I think that makes a lot of impact on the listeners. So let me just ask Dr. SHIV one question and Dr. SRINIVAS one question, then we move on to questions asked by the audience. Dr. Shiv, what practical situations I have faced when I was mentoring some SNCUs in Karnataka was that they don't have Cpap. So they're not taking care of, say, less than 28, less than 1 kg babies anyway. So they had to buy non-invasive respiratory support, and they asked me, so what would you prefer? Would you prefer Hfnc, or would you prefer a bubble Cpap machine for them? And can you justify your answer?
I mean, for babies more than 28 weeks?
Yes.
Yeah, about 28 weeks, and if the baby is above 1,000 grams, then you possibly can try it, but the failure rates might be high. Depends upon the severity of RDS. If your RDS is quite severe and the indication for it is just mild to moderate distress, then perhaps if you don't have Cpap, then you might try it, but the failure rates are high. So caution is required, and someone who can monitor this is also very important. So it depends on various factors. So yeah, Cpap would be ideal. If you don't, then HFNC. Yeah.
These are centers like they don't have any invasive support anywhere. They may or may not have surfactant. May or may not have trained, skilled manpower throughout the clock, and they have to buy a new machine. So would you advise them to buy a HFNC machine versus a Cpap machine, or vice versa?
So currently I would go with, it's from my personal experience and, whatever evidence is, to go with Cpap for being most cost effective than HFNC. I may be wrong, but that would be my answer. Yeah.
Right. Thank you.
Shashi, can I add one more thing here?
Sure,
with your permission.
Yes, sir. Yes, sir. Please.
The thing is, what Dr. Shashidhar mentioned is a real big problem, and probably in our country, I believe. And it is not that easy to solve this issue because, as we discussed earlier, HFNC is not less expensive either, right? And if you take in terms of nursing care, it is not different from what you do it for CPAP. So actually, I don't use HFNC here in JSS just because of that, because we are doing the same thing what we need to do for CPAP, but we are giving some unmeasured pressure. So only place where I think it is probably something which is seriously considered is when you have the nasal injury, big children where they don't tolerate the CPAP gears and they just move out and pull out everything, then probably this can help. And I would like to take this platform to inform that to address this issue, I have devised what is called as simple CPAP. It is under patent process, and I'm getting it manufactured probably in next 4 weeks. We need to have the prototypes. Dr. Shashidhar, I want to mention here that all the problems that you mentioned, I have tried to address in that, where we can give a CPAP, that is the measured pressure, with a low flow, that is a flow less than 2 liters, so that humidification is not a major requirement at that stage. And the second thing is, it uses the ordinary nasal prongs available on the store. You don't need any special gear for it. You don't need HFNC cannula, you don't need anything. You just use the ordinary nasal prongs, probably of a little bit bigger size, because here in this system that I have developed, you don't need to really give that much of leak, because it is preferable not to give a leak, because I have made a mechanism for expiration. So probably this was the same problem that you are telling was bothering me for such a long time. And currently we have come out with a prototype, which we have made an in vitro study, and now I'm getting it manufactured. Probably if we meet again sometime later, we can take it further as a group rather than individual studies. So I just wanted to put it under the platform, but I understand that's a huge problem, and we need to find our way of solving it rather than looking around for Western people to give us something for it. So just I want to make that thing. It is called a Cpap as of now.
So I think one more patent will be coming to you recently. We're looking forward to that. So one question I had for you. So what is happening in tertiary centers right now is people are quite hesitant to put the baby on bubble CPAP, especially these less than 28, less than 1 kg. When they're going to have apnea, probably they may require surfactant, they may or may not go into invasive ventilation.
Yeah.
So what they're preferring is a ventilator CPAP, when you can easily change over to a non-invasive positive pressure ventilation if required. Say baby develops apnea, you just switch it. Yeah. Or if baby develops just as a bridge for invasive support. So do you think we are underutilizing CPAP in that way or overutilizing ventilator CPAP? And is this the right way to go about it?
I think you're really on the spot. We have the same problem, because most of the time when we say the nurses to either set up a bubble CPAP or a ventilator CPAP, it is our own sort of perception. You know what I mean? depending on the size of the baby, the look and the distress, etc., etc. And I have made it a point that we will start with bubble CPAP always and then change over to ventilator CPAP if needed, or ventilator whenever we need it. And I am not using NIPPV as the interim, as I told you, because I'm still yet to be convinced about it. So our protocol is to use CPAP, bubble CPAP, 1.6 crosses, then change over to ventilation. A lot of the time, the nurses are very unhappy with me because of that, because they have to just do all those things. So I think let us be pragmatic. If you think that your nursing staff will be very unhappy with the way you're doing things and you don't want to keep them in a bad mood, yes, please go ahead with the ventilator CPAP so that, it will at least keep a good mood in the workplace. But here, because I have the privilege of commanding certain things, I do use bubble CPAP in the first place. But having said that, again, in the night, CPAP in the beginning. And as I told you, we are not using an IPPV in the interim. That's why we are using bubble CPAP, 1.6, intubate, surfactant, ventilate for a short duration, extubate to CPAP again. And then if needed for apneas and all those things, we may go for NIPPV. But again, as I told you, when we change from bubble to ventilator, we have this murmuring and all those.
So we have to change that and open a new humidifier. So
yes, it is pretty much they will kill us. Honestly, when you say change from the bubble to this one, they feel very unhappy. But yes, that is happening. Yeah, we need to be pragmatic and take according to our unit's requirement and availabilities and resource. For example, if you don't have many nurses, you can't just keep them doing all these things. Then probably go with the ventilator CPAP, and if you want to use an IPPV, feel free. But only thing I wanted to impress here is don't have a wrong impression that NIPPV is as good as CPAP for adverse effect and as good as IPPV for the outcomes, respiratory outcomes. That is not true. That is something which is not proved yet, and I am seriously questioning each and every article that is coming out of it. But let us accept that there is a place for it. If you can manage a baby on NIPPV without intubating, do it. But not thinking that it is better than IPPV, might be it is equivalent. But if you can manage, why would you intubate? Because injury related to endotracheal tube is reduced anyway. So let us go and do it. But let us not have wrong impressions about it. That's the only thing I wanted to impress in this presentation.
Sure. So we have a couple of hands raised. Can we please unmute Dr. Naresh Prasad? Yep. Dr. Naresh, can you ask your question? Dr. Naresh. Okay. Dr. Srinath.
Yes.
Yeah, I think Dr. Naresh.
Dr. Naresh,
Yes.
Dr. Naresh,
Yes,
are you
yes.
there?
Yes. I'm asking my question. Is there any long-term sequelae with the non-invasive ventilators?
Sir, the question is for whom, sir?
Are there any long-term sequelae due to the non-invasive ventilators?
Yeah, I understood the question. You want me to answer or Dr. Shiv to answer?
I think you can answer that, sir. It's related to
Now,
your
there
topic.
are no studies, or I would say prospective randomized studies to see whether NIPPV has a long-term advantage over IPPV. There are no studies. The one retrospective study that I mentioned from Harish Kriplani group was done a few years ago. They have included a large number of patients. They did not find a difference between CPAP and NIPPV. They did not compare with IPPV. In both the groups, 60% of them received IPPV. So I think the answer for the question is I don't know as of now.
Sir, when
invasive compared to non-invasive, definitely invasive has more of a sequelae long term than non-invasive. Non-invasive definitely safer.
That is exactly what I was arguing, because when you say non-invasive, if you see all the articles, they have included all sorts of support, including oxygen by head box to NIPPV. I think NIPPV has a gas transport mechanism very similar to IPPV, and nobody have bothered to separate that one in that sense. So that is the reason why I refuse to accept that conclusions without contesting. Because when you group unlikes like CPAP and NIPPV, I think it is a bit unfair. because the respiratory mechanics is very, very similar or probably closer to IPPV rather than CPAP, because you are pushing the gas into the lungs. So we don't know what harms we are going to do. And nobody have really teased out that part. And that is my concern. So I wouldn't really buy that argument that it is better than invasive. It's only IPPV. But you want to say CPAP? I completely agree with you. Yes.
Sir, in which situation when one has to switch on to non-invasive to invasive ventilators?
We use SOPI of 1.6, sir. SOPI of 1.6, we will switch.
Yes, sir. So, does this non-invasive ventilators will help in the RDS with a collapsed lung or with the similar conditions in found in the newborn period?
It does help. Not that it is bad or a demand. It does help. It is definitely, it is any mode of ventilation that can be used. I'm not against it. I'm not at all telling that. But is it going to cause less harm than invasive IPPV? We don't know. We don't have any comparison so far. So we should not make some sort of assumed conclusions of it superior to invasive ventilation. That's all I'm trying to argue. But it has a place. It can help in RDS. Yes.
Sir, what are the parameters you consider for the non-invasive ventilators when the patient is improving or deteriorating?
Okay, in my unit, we don't use non-invasive ventilation before intubating the child. We use only CPAP, and if the CPAP fails according to SOPI, we will go for invasive ventilation. That is the protocol. Only after extubation, if the baby has more apneas on CPAP, we are going to switch over to NIPPV. That is the only place where I am using as of now. So probably my experience in that is limited. Probably somebody else who might have used can help you.
Thank you, sir. Thank you very much.
Thank you, sir.
Dr. Srinath?
Srinivas.
Yeah, Srinath,
Hi. Excellent presentation. I really loved it. Sorry, I missed the initial bit of your presentation. Okay. And I completely agree with you. The nasal CPAP should be the standard of care for primary. And I have been using actually NIPPV for last 2 years. That is only for CPAP failures. Yeah. And maybe if the baby has recurrent apneas, as you rightly said. And I'm actually able to prevent invasive ventilation, and it has been really useful. And I also completely agree with you. And NIPPV cannot be really compared to CPAP. And in the talk in the same breath, definitely CPAP is least barotrauma and polytrauma compared to the NIPPV. But Srinivas, one thing I want to ask you. What interface do you use for NIPPV when you use? What interface do you use? Do you use Ram's Cannula, or what exactly do you use?
The mask. Huh? Mask, or sometimes the CPAP, what is that? Short binasal prongs.
Short binasal prongs. Okay. Yeah. So one question I want to ask you, Srinivas, is see, especially we may not have delivery room CPAP. Right, majority of the units.
You don't have
also, it is very tricky when you are actually transferring the baby from some other smaller hospital to your hospital.
Correct.
There, what I found was using a Ram's Cannula, either to deliver CPAP, or if the CPAP doesn't work, maybe to deliver IPPV via the Neopuff. I found it really useful. Yeah. And until we transfer the baby to the NICU, where we can actually put the baby on standard bubble CPAP. Yeah. So what is your opinion on that?
I completely agree with you. Ram's Cannula will give some amount of CPAP, which is again unmeasured. Right? So it does have some beneficial effect. There is no doubt about it. And it's exactly what I was trying to do. And whatever the CPAP I told is for short duration, for transport and short durations. So the problems that we are trying to address is in the Ram's Cannula and high flow nasal cannula, you don't have the measurement of CPAP. Whereas here we don't actually measure and display, but we have set the maximum pressure that can be generated by that. So with that flow rate, you are going to consistently give that much of pressure. So that is something which is assured. The second thing is, again, the interface is very similar. I mean, it's a nasal prong. So I don't think the Cannula is different from that, except for the caliber and all those stuff. And the hub of it, which is a little bit different. It is a plain nasal cannula, I would say. So that's one thing that we are adding. Again, as Dr. Shiv mentioned, similar to high flow, you need to have a leak when you are using trans cannula. Whereas the one which we are trying to do is to make sure that even without a leak, you should be safe. So probably that is going to come up. But for now, yes, Rams cannula does give some PEEP, and I agree with you. It does help. Better than not giving anything, of course.
Because I had some discussion with Dr. Ram himself, who invented this cannula. What he told me is it delivers 2/3 of the pressures that you give.
Yeah.
If you're giving Cpap, maybe you can give a Cpap of 6 or 7, and probably you may get about 5. And similarly, we are using it on a short-term period when we are actually transferring the baby to the unit. And also, sometimes I'm using, if I find that if you are using the Cpap mask and it is causing a lot of indentation, and if you do not have the proper prongs, then I'm using it for a shorter period to deliver even Cpap, and it has really worked. So
it is true. I did speak to Dr. Ramanathan when I went to Los Angeles, and I did, when I was developing the Cpap, I did have contact with him for a while, just to know about all those things. The number that you have taught, that the 2/3 is basically based on the static studies. Okay. You put it on the artificial lung and measure the pressures or in a mannequin, and then you can get all these things. But in a breathing baby, nobody knows. Yes, it does probably give 2/3. Only concern is it is unmeasured, but it is better than not giving anything. I agree with you.
Yeah, true. And we will be eagerly looking forward to your
very happy to share
trials, randomized trials that you're doing, and it will be probably eye-opener for all of us.
Yeah, hopefully that will answer many of the questions or many of the concerns that I have. So I will change my practice, or probably explain with more confidence what I have told today.
Thank you so much. Really enjoyed it. Yeah.
Thank you, Dr. Srinath. Dr. Amit Suyal, can we unmute Amit?
Yeah. My question is to Dr. Shiv. First is regarding when we are ventilating a baby, when you're talking about the compliance curve, you said that the best thing is the optimal ventilation takes place in the middle part of the curve. So how do clinically we try to be in that? How do we know that we are in that part of the curve? Can you tell us some things on bedside?
So if you have a ventilator which can show your PV loop, to use the ventilator with PV loop, you can go on the loops, because there's scalars and loops. If you press on loops, you'll clearly get a curve of compliance. You get two values, one is C and one is C20 by C. That is two values. C20 is your compliance during the end of your lungs, end of expiration. That is what is your compliance. So if your curve is very steep, it's in the middle, then you can probably know that you're ventilating correctly. Okay, and if it's falling, towards the horizontal axis, then you might have to overextend. Over-distend, little bit distant, provide more PEEP. Okay, and if your curve is towards the horizontal, vertical axis, then probably you are over-distending it. And you can see your C20 value. Okay, C20 by C value as well. That also shows what you are distending at the end of expiration.
No, but when you are seeing the C20 by C, it's such a dynamic value. Every breath it keeps changing. So how do you try to know? Because that's so dynamic, we will never know how do we mean it out or average it out as to what we are ventilating. It's so much dynamic. Until unless we paralyze a baby and see that C20 by C, probably we may be seeing a constant figure.
Correct. Babies, we don't need really to paralyze and even sedation unless they are moving against the ventilators or not synchronizing. That's not ideal to ventilate or paralyze the babies. Again, it's a dynamic things. It's the average. That's why you have to go with the average values and also see your curves. That's what clinically we can do in a dynamic setting. Unless you paralyze the baby, which is usually in the bigger babies. Smaller babies, it's hard. So you see not a one value, you see the average values like you see in volume guarantee, you don't see one values. So perhaps it's, like that. Yeah.
Okay, the second thing is regarding the time constant. Now you said it's a compliance multiplied by resistance. Each time, whenever we get a baby, can we individualize with each baby this time constant and figure out what is the TI of that particular baby and set it accordingly? Is it a practical method, and how to go about it?
See, so time constant is again, it is individualized based on the pathology of what the baby is having.
Yeah, so the ventilator is going to give us a compliance and resistance now.
Yes.
So if we multiply and multiply it again by 3, coming it to somewhere around 95%. So can we set it as a TI so that we individualize and personalize with every baby? Now we are roughly keeping it like 0.3. But if we do it by this way, is it more practical? Are there any studies saying that should we go by this, or we take the thumb rule of like 0.3? 0.35
so again, the thumb rule. Okay, there is. I'm not aware of any studies which have done studies on time constant. Again, it's not a thumb rule. It's about the pathology. If you're dealing with something which the lungs are collapsed, okay, or if you're dealing with very stiff lungs. So, or even for example, in RDS, the mechanism in RDS is your decreased compliance. So you have to provide with the resistance is normal. So what happens if the airflow? Resistance to the airflow is less. So if you provide a longer time constant, you are pushing more air, and stiff lungs, more air, you might end up having pneumothoracis. So you probably ventilate to get higher minute ventilation. You have to go up, along with tidal volume, you have to go up on the rates. So short I times, your I times would be half as long as your E times. So 0.3 to 0.4 up to 0.45 is okay. If you're dealing with RDS, if you're dealing with meconium aspiration, sometimes you go up to 0.5. So probably that is the average value. In BPDs, again, you can go up to 0.5, 0.55, depending upon how bad your lungs are. So, that's how we do. Yeah.
Yeah, and that's right, sir. But when we come to applying this knowledge, this never comes as a time constant. When we calculate the time constant and figure out a TI, it never matches with what we are practically setting. That is why I wanted to ask this question.
Yeah, Dr. Amit, I think your answers, your questions are more related to pulmonary graphics. So how you can make out the time constant, whether your I time is adequate or not. I time is definitely based on time constant. And how you know I time is adequate or not is by looking at the flow scalar. And in the flow scalar, you have to see there is a adequate transition from inspiratory flow to expiratory flow. If your I time is too long, the inspiratory flow is not followed by the expiratory flow. It is followed by a pause. So you try to reduce I time in such a case so that there is an inspiratory flow transitions to expiratory flow. So you have to always look at the flow scalar to adjust the I time, and in turn also it is based on the time constant. So starting with, you make it 3 times the time constant, the I time, and later you fine tune it based on your inspiratory scalar. Regarding the question on compliance, as Dr. Shiv said, the PV loop, when you see on the ventilator, that's a dynamic compliance. So, but you never see that the static curve, the sigmoid shaped curve on the ventilator graphics. So you have to base your decisions on the PV loop itself. The easiest way to see is just by looking at it if it looks like a parrot beak. So if it shows beaking in every breath, so try to reduce it till the beaking is reduced and you get a nice standing good hysteresis curve. You can also go by the C20 by C, as Dr. Shiv said, but this this one is more on pulmonary graphics. I think NNF is planning to organize seminars on pulmonary graphics. Please attend that also.
Right, sir. So I have a couple of questions for you, sir. First thing to Dr. Srinivas. This is regarding the first thing is regarding the leak compensation in non-invasive ventilation. So we obviously expect a leak in a non-invasive ventilation. And can this leak compensation, how does it work? Or if it overshoots, can it be dangerous to a baby causing air leaks?
Right. Okay. So let me clearly tell that whatever we are doing with all these machines are more of theory based. I don't think that there is any evidence to say that this is going to help the baby in better way than the other. But I think it's more of the time it is common sense which dictates that yes, if there is a leak, if you can compensate, then that will be better. Probably that's it. I don't think that there's any study or any evidence in the human beings which says that by doing this you can actually improve the outcome. It's only the mannequins and this thing. Because
another thing regarding the SOP index, sir.
Yeah.
So suppose if we are having now this one, when we are calculating this, if somebody has set for a same baby the PEEP of 5 and FiO2 of 60%, and it is showing a saturation of say 98, and the same baby if somebody has set a PEEP of 8 with FiO2 of 100, and again the saturation would be 99 to 100, the two figures will be grossly different. Is there any prerequisite to how do we calculate this SOP index to be genuinely true?
Yeah. The thing is, if you see the formula, we have included both FiO2 and PEEP in the formula.
Correct.
The reason is, when I worked in different units, there were units where they would not touch the PEEP. Even in our days, I'm telling this 20 years ago, probably this has changed now. They wouldn't change the PEEP and they would just go on the FiO2 and then probably go for surfactant. And there were other units where they would just not bother about increasing the FiO2 at all. They would just go for the PEEP of 5, 6, 7, and particularly in Melbourne, we started with 7 actually. So in order to bring about this uniformity, I have created a product of both of them. Suppose if in your unit, you are more tuned to increasing the FiO2 rather than PEEP, then go ahead.
Yes.
Still, the SOP will go up because it is a numerator, right? So in our unit, what we do is, this is what we do practically. If the saturation is issue, then we are going to raise the PEEP once and then touch the FiO2 button. If it is the distress which is more and if the saturation is maintained, then probably we'll leave the FiO2 there and we will tweak the pressures to a higher level. And obviously we'll calculate the SOP every 10-15 minutes depending on the thing. But yes, both of them are included in the numerator. So whichever you increase, the SOP is going to increase. I mean, 100% oxygen for a baby and RDS is very bad, you know what I mean? So naturally, if it increases SOP, you are going to change the gas.
Right. So another thing is regarding, we know that the most natural way of ventilation is a negative pressure ventilation.
Correct.
And we have a negative pressure ventilator in the world, that is the biphasic QRAS ventilator. What is your take on newborn babies using the biphasic QRAS ventilator?
I don't have any experience. Honestly, I don't have any experience. I mean, it's a good concept, but no, I don't have any experience.
So, and so the last question regarding whenever we use a non-invasive modality in a pediatric age group, we usually go for the, to look into the sensorium of the child. In case of neonates, is there something of that sort before we put on a non-invasive ventilator?
Practically, it's so difficult. You could have a baby who is very agitated and the preterm baby who is very exhausted. So I don't know how far we can do it. We go with the pain scale of an IPS. And that's it. We don't have any other way of measuring or assessing the consciousness of the baby other than report. Like
so then,
active, and etc.
Okay, so then what is your take on feeding such a baby on a non-invasive ventilation? Now, there is more prone for aspiration because we have not assessed the consciousness.
Yeah. So, sorry, I don't know whether I took your question in the wrong way. I mean, we could use non-invasive ventilation in a baby who is not comatose, because if he's comatose, we are not going to use non-invasive ventilation because they need to have spontaneous breathing. They need to have at least a little bit of orientation around what is happening. So feeding is continued as usual. There is no change in the feeding protocol. If there is an aspirate, we are going to hold it back. But if the baby is very lethargic and if the nurses and that the baby is very sleepy and not those things, I would rather change to invasive ventilation rather than keep it on non-invasive. I am not at all happy with that. So I'm going to keep it, get things under control so you can better do a better job. That's my experience. Obviously, if people are used to non-invasive, they can do it in a better way. But my experience is a bit limited to post-extubation. So even if for some reason, if they are on an IPPV in the beginning, if they are very lethargic or they are not very active, if the nurses report that we are not happy, then we are going to go for invasive ventilation.
Right. So thank you so much, sir, for all that.
Thanks for your questions.
Yeah. Dr. Sanjay Chaudhary.
Yes. Hello.
Yes, please go
Hello.
ahead.
Can you hear me? I'm from.
Yeah, we can hear. Please go ahead.
I am from Siliguri, West Bengal. I've been in your program since last say 15 days, and I am enjoying really. I had few queries regarding this: how to prevent the injury to the nose, nasal septum, and bridge. while on Cpap. First. Second is that if a baby is doing well on high flow, more than 1 kg, then why to go for a Cpap, which is more injurious to the nasal septum? These are very practical questions. So these two queries I am having. Otherwise, all the queries was answered.
So who's Shiv? Yeah.
Yeah. So regarding to your first question is how to prevent nasal injuries. Most of the nasal injuries are due to the nursing care per se rather than the interface itself. If we have got a good nursing care, then that can be prevented. Of course, even with good nursing care, there are chances of nasal injuries. So you have to look into certain factors. Is first the size of the nasal prongs or the mask or any other interface, Ram's cannula if you're using. So you need to look into, whether it is adequate size, whether it is tightly fitting, and there is a little bit of gap between the orifices, and also it shouldn't touch your columella, this part. So it should have a little bit of space between that. And your alae nasal should not be flaring up or should not be too tight, or there should be no redness on your alae nasal. And most importantly, second important is your humidity and the temperature. If you're giving your humidity is not appropriate, or if your temperature at which you are giving the air is very cold or too hot, then it initiates that nasal damage. Then other thing is the monitoring. You should have a thorough nasal scoring chart in every shift, at least once in a shift. If someone the nurse taking care of your baby, if they watch and make sure that all the tick boxes are done and there is no initiation of any nasal injuries, then that can be prevented. So you can prevent the nasal injuries by all these things. Second question is, if the baby is about 28 weeks and about 1000 grams, if you be with minimal RDS to moderate RDS, if the baby is doing well, if you are doing a good job, your SARS scores are coming down, then it's helping. But if the baby is worsening, which you will know in a few hours after application of HFNC, then perhaps it's not a good idea to continue of HFNC, because you will end up failing more often than not. So if you're getting successful, then yeah, but maybe in severe RDS, if you're still getting successful, maybe it's by chance and not per se. If you do it regularly, you might see more failure cases as well. So mild to moderate RDS, if you're being successful, then yeah, you can use it. But still there is not much of evidence on it. Yeah.
Okay. Another query, can I go? Hello?
Yeah.
Please.
Yes. How much leak can we allow in a ventilator if the baby is in NIPPV? First. Second thing, you are saying that in NIPPV, if we use Ram's cannula, there should be some gap for that. Do that allow good NIPPV without leak? Because there will be lots of leak through this. How much pressure to go? And another thing, you set a rate of 25 for a baby on NIPP. Why so the rate is very less on those babies?
Okay, if I have understood your question right, suppose if you are putting a baby on non-invasive intermittent positive pressure ventilation on ventilator, so how much leak you can accept, or your question is how much leak we have to deliberately execute?
How much leak we can accept?
We can
how much? Because on Dragon ventilator, they show the leak like 70%, 70. We know that up to 40% the ventilator can compensate mostly. Can you elaborate on that?
As long as you can put the gas into the lungs, you can accept whatever the amount of leak. But more the leak, it is becoming very inefficient way of doing it. So generally around 20 to 30% is what generally we are comfortable with. But anything more than that require compensation. But having said that, if the ventilator cannot compensate, the patient is going to fail. But irrespective of the leak, if you are giving the NIPPV and if the baby is stable and improving, then I would say just concentrate on the baby rather than the leak. There is no number telling that beyond this leak you have to change anything. I don't think there's any number of that sort. Basically, it is the objective of getting the gas into the lungs. If that is achieved, that's good. If that is not achieved, make arrangements. That's it.
I think the second question was why such low rates in NIPPV?
Okay.
Yes.
Yeah, that's my choice. That's all. Sorry, I think I should have told it earlier. It is what we follow because we wanted to use NIPPV as something, an interim between re-intubation, extubation and re-intubation. So we put a rate below what it was set, like 15 or 20 or something like that, because baby will be spontaneously breathing, and in between he will get some sort of sigh breaths with this. That is our, I would say, not understanding, probably our assumption. It might be wrong. So that's the reason why we keep very low rate. Yes, I know people who can use a higher rate. There's nothing wrong with that. I'm not telling this is the right way to do, but that's the way we are doing it. That's all I told.
Is synchronization is possible with the flow, flow synchronization that the ventilator is having for IPV? The same sensor will work in an IPPV?
Yes, you can. You can put a SIMV on when the baby is on an IPPV. But is it going to help or not is something which we don't know. Some of the studies have shown it is better, but many of the other studies have shown that there is not much of difference. But if you can use it, use it. So there's nothing wrong with using a synchronized way of doing it. That's probably more of common sense based rather than evidence based as of now.
Okay. Thank you very much.
Maya sir's hand is raised. Dr. Maya sir, can we unmute?
Yeah. Hello.
Sir,
hello.
Yes, sir. You can continue.
Hello.
Good evening, sir.
Good evening. There's no question. It's only to comment.
Yes, sir.
I think both the talks are excellent. I can only put in one word by saying that they are very good teachers.
Oh, great. Thank you.
And second thing is, I thoroughly enjoyed because my experiences, in the sense, almost 45 years.
Yeah.
First, I was trying to give the positive pressure to the bag and mask in 1970s. Used to put the, postgraduates on rotation to do the bag and mask. Then subsequently endotracheal tube and then the positive pressures. Again, it's all experiments only. It's the 1970s.
Yes.
Later in Ramaya, when we started giving the Cpap by ventilation. This is while weaning. And subsequently, Dr. Prashant brought in the, bubble Cpap. And I think we were the first ones to, report from the country. I think this is how that, so much of advances. I thoroughly enjoyed your lecture. Thank you very much.
Thank you so much for your compliments, sir. We have learned a lot of things from you, and it is a great thing to hear such words from you, sir.
Thank you, sir.
There is one more question which has come to me from Dr. R. He asked, how can we convert ventilator Cpap into bubble Cpap or HFNC? By what interface and blending machine with inspiratory limb? I think anybody can answer that, if anybody can.
You can't convert ventilator Cpap into bubble Cpap, so that is going to be futile. But if you want to convert it into HFNC, you can use just a single limb and a prongs and give the humidified gas. That's all. It's not very difficult to do it. You can't convert it into bubble Cpap, no.
Okay. Dr. Prashant, any more questions from your side?
No. Dinakar sir, any questions which has come?
I have one question for anybody can answer. What is the difference between NIPPV, SIPPV, DOPAP? NIPPV, SIPPV, everybody knows synchronized. What is the difference between DOPAP? Is it same word of SIPPV?
I don't know, sir, honestly.
I have not heard of that.
No. Shashi?
Dr. Dinakar's question.
Hey, don't blame me, dear. Don't blame me.
Is it invention?
No, not like that. Just no. It is all opening the eyes. Okay. See, DOPAP is a simple company name, brand name. Oh. SIPPV is the same. The company has kept the name called DOPAP.
Okay.
So DOPAP can be used in a single limb or double limb. Okay. You know what is single limb? because single limb we do use it for variable Cpap.
Yeah.
Variable Cpap we do use single limb. In double limb we cannot use the variable Cpap. But DOPAP can be used in a single limb as well as the double limb. You know what is single limb and double limb? If anybody is still there, I can show you the video. Video means what is that? 1 second, hold on. And I have one more questions to everybody. Just this is the one. I think so. You people can see it. What I am. Prashant, can you just show my video to this thing, people?
1 second. Sir, 1 second.
I'm usually normal here.
Yeah, you can talk, sir. It will come automatically. It will come.
Okay, is it correct what I'm doing? Correct now? Yeah. See, in non-invasive mode, if I'll touch the non-invasive mode, can you touch it? Yeah, non-invasive mode, there is a dual limb, single limb is there. In dual limb, there is a nasal Cpap, NIPPV is there. So in single limb, same thing, nasal Cpap, that is called a variable Cpap. DOPAP, same thing, it is a synchronized. Because during the expiration and this thing, it is better. The company has kept a DOPAP or BiPAP. We know that. That is only a company's trade name. And one more thing is just be there with me. Where is that single limb? See, this is a single limb Cpap. Single limb, just it is like this. What is it? You can see the nasal interface. And this is a single limb thing. It is available in all the companies everywhere. And this is the connection. Here, Dr. Shiv, your Shiv Shankar, some people were having the doubt. Nasal cannula, that what we have. You people can see there are things are from CareFusion ventilator things. Some things like a Neotech Rams cannula. What is the difference? If you will go to, because you should know when you are using. Because I stopped almost some 6, 7, 8 years back, I think so. No, I think so 10 years back, I stopped using, I don't want to tell, one company's nasal interface. Because it was causing much problem, like a nasal injury. So I switched over to the bubble Cpap also. The same thing, high flow nasal cannula, this thing, like this, high flow nasal cannula. But only problem, we used to use, we have to use a smaller thing that Shivu has showed you. It should be at least 2/3 only, it should cover. Suppose if I am using for NIPPV also, we can use the same cannula. Even for nasal HFOV, we can use it. But what Shivu was telling is this. Can you hold it? See, I am coming near. I don't know. Okay. See this nasal where I am showing. Can you just turn it up? Okay. No, you are turning too much. Yes. See this one. Okay. What we are seeing, the nasal this thing, the out where it is coming out, it is narrow. But if you will take the other things, can you hold it? Just like that. Okay. See, it is broad. It is broad. If you will go to the CareFusion, it is more broad. Not CareFusion. This is CareFusion.
So keep it little far. Don't keep it too close. Don't keep too close to the camera, sir. Little far. It will automatically focus.
Do like this. Pull. I think so. You people can see. Why I want to tell you is DOPAP is the same thing, but even acute-chronic, all the things will be having. And one more thing, somebody was asking the question, Dr. SRINIVAS, whether can I use in non-invasive ventilator sensor? Somebody was asking that question.
Yes, you can use.
This is the sensor.
Yes, technically you can use, but it is less efficient.
But one thing, sir, there is no much use. There is no much use in non-invasive things if you will use the sensor, because even non-invasive mode, there is, if mouth is open, there will be definitely leak. Definitely leak. Yeah. But if you will use in synchronized mode, like a single limb, synchronized like a DOPAP or that thing, then if you will use the flow sensor, then only it is useful. Otherwise, like for CPAP or normal NIPPV or what is that nasal HFOV, we should not use, because there is no use. Machine will keep on giving alarm. There is a leak, there is a low pressure. So flow sensor is no useful. If you are using single limb, DOPAP, BiPAP, then flow sensor is useful. So there is one more small thing, sir, for SRINIVAS, sir. SRINIVAS, it is for you. One small question. It's only together we are doing it. Okay, number one, NIPPV, do you think, because you have done SIPPV, I have read many articles what you have done it, I have read many articles, SOPI and all those things. Really, NIPPV is better than CPAP. If it is better, do you think that is the only better one compared to the non-invasive HFOV? Because you told it will cause better one.
Okay, so let me clarify this one. Suppose if the, I'm just putting a scenario. Let us say the disease severity is not very much, and the baby can be handled by CPAP. In that case, you can also handle that baby by NIPPV. There is no point in giving that one. So we have to manage with CPAP. If the disease is severe, then they are not going to be better with CPAP. They are going to fail CPAP. Then what next? Obviously, NIPPV will be better than CPAP because it is pushing the air into the lungs. Whereas CPAP does not do that job. It allows the baby to breathe. Whereas the NIPPV is going to push the gas into the lungs. So in that way, yes, it is better. But when it is better, when the CPAP has failed, you have to use that one. But if you are using NIPPV and the CPAP can do the job, I think it is a bit of an overkill. So I wouldn't consider that as better because it can have more adverse effect than CPAP, at least for argument's sake, I would say. So for a baby who is having the disease severity sufficient enough to be cared by CPAP alone, putting them on NIPPV or invasive, whatever it is an overkill, and I think we should avoid. And if the baby has failed CPAP, then yes, we need a positive pressure ventilation. If you want to choose an IPPV before IPPV, please go ahead. There is nothing wrong, and definitely it will be superior because it is going to shove in the gas into the lungs. That is the reason why we have designed that study where we take CPAP failure as the entry point for the study.
Yeah. Sir, somebody has asked one more question. Sir, how to calculate the compliance? Sir, it is very easy, sir. Somebody has asked the questions with the compliance. Sir, I know, sir, C20 by dyne, that is really good because it is more better than the compliance ones. If you are having in your ventilator just the tidal volume, how much it is going, just tidal volume divided by the pressure gradient difference. That is nothing but PIP minus PEP. Suppose if in 3 kilo baby, if you are giving 14 ml, so tidal volume is 14 ml divided by pressure gradient. Suppose if you are giving the pressure 18 by 4, so that means the pressure gradient is 14. 14 is the tidal volume divided by 14. The compliance is 1. So the normal compliance everybody knows. So how much is the normal compliance? How much is the resistance? C 20 by this thing, C 9. So that is the easy way in case if anybody is not, I mean, if the machine is not having the compliance method, like an old machine or anything, it is better way to do it, calculation. So anything, sir? And Dr. Shivu, for you, one small question. Is it okay, sir?
Yes,
Dr.
sir.
Shivu?
Yes, sir. Yes, sir.
Shiv-Shankar?
Can you?
Okay.
Yes, sir.
Is there any difference? Is there any difference in lung, I mean, preterm and term respiratory physiology? Is there any difference? Why nasal high flow cannula you told and the Cpap, as it comes to NIPPV, is there any difference as in extreme premature baby or preterm and go to the late preterm and term? Is there any difference?
You mean you are asking about the physiological difference, or there
Yes,
is?
boss.
Yes, sir. Yes, sir. There is definitely a difference between, if you compare preemies and term neonates, there is a huge difference. You know, compared to right from the chest wall compliance, the resistance, the airway diameter, you know, the surfactant deficiency, and the way they breathe, the immaturity of the lungs, you know, the respiratory center. So there are a lot of differences between them, you know, between preterm and term neonates.
Yeah, sir, why I asked you, Shivu, that
Yes, sir.
question is, see, it is not like something everybody we should learn. Every day we are learning. So one thing why I am telling is, see, HFNC usually we do use for a larger babies. We
Yes.
don't use really at a time for a smaller. I don't know, but at least I am not using. I have that much experience only. So because of this respiratory problem in the larynx and in the pharynx, what is that problem in the larynx and pharynx is, if I will throw little flow, more flow, so what happens? Glottic area will get closed. Like a NIPPV, why I am not much towards that NIPPV or SIPPV, I know better than the Cpap. So like that, if you'll throw the flow, more flow, like 4 liter per minute, 5 liter per minute, 6 liter per minute. Because in usually Cpap, nobody will go more than 6 liter to 5 liters to 6 liter, max to max 7. But in HFNC, usually we go start from 6 to maximum, at least according to the weight, 0.5 to 1 ml per kg. If we will flow that much flow to the pharynx and larynx, it will have a glottic constriction. Like if you will blow air into somebody's eyes, how protective mechanism eyelid will close, like that glottic will get closed. If it close, what happens? 2 things will occur. That is called Cpap tummy or NIPPV tummy will come. Number 1. Number 2, what happens? Obstructive apnea, Cpap will prevent. But if the flow will increase, you see baby is not so much comfortable. Even in NIPPV, if the PIP will go more than 20, NIPPV baby, bigger baby might tolerate, smaller baby won't tolerate. So because of the stretch, it will go for apneic spells. We are giving the NIV to prevent the apneic spell, but we are inducing the apneic spells because of overstretch, reflex, that central apnea and other things. That is the reason this talk, what we have given to you, Shivu, very, very important. Respiratory physiology is very important for preterm and term. Thank you, Shivu.
Thank you, sir. Thank you. Yeah.
Thank you, sir. Over to Prashant.
Yeah, I think all the questions have been answered. There are no more questions and there were no more rise of hands. It's indeed a wonderful. Yeah, it's indeed a wonderful presentation. There's no doubt about it. And we know that both of them are phenomenal. And our senior Dr. SRINIVAS sir, who has been a teacher for so many years and so many students have learned under him. And Dr. Shiv, a young and dynamic chap, fantastic presentation, fantastic information which has been recorded, and it is available all on our social media, Facebook, National Neonatal Chapter Karnataka, Please log in. If you have missed, you can tell your friends, or if you have not understood any specific things, or if you're busy with certain things in between you could not hear, every piece of information is recorded. It's there in YouTube channel as well. So our next topic is on conventional ventilation strategies with and volume guarantee as well, and acute deterioration of neonate on a ventilator. So that will be our next topic, which will be happening on 9th of June, that is day after tomorrow, Tuesday. Do not miss to join. Please tell your postgraduate, your friends, colleagues. Thank you very much once again. And thank you, Dr. Shashidhar, for moderating the session. And I would like to thank all the participants who have shown such keen interest and who have been with us for such a long time and still showing the same level of enthusiasm and same urge of learning things. Thank you very much. Thank you. Have a happy Sunday evening. We'll catch up day after tomorrow. Thank you, Srinivas sir. Thank you, sir. Thank you, Shivshankar. Thank you,
Thank you, Srinivas sir. It was a pleasure sharing forum with you. Thank you so much.
Thank you so much.
Thank you.